My name is Jonathan Dortt. I'm a general surgeon and MIS surgeon, and I'm the co-chair of the Quality Outcomes and Safety Committee for SAGES. I put down I have nothing to disclose. That's actually not true. I thought about it. I have two things to disclose. The first thing is that I'm a product of the Navy's HPSP program, so I have a significant service bias that has to be applied to this talk. And second, which may not affect anything that I say, but and secondly, the other thing I should disclose is I have absolutely no expertise to tell you what I'm talking about, and I think that's the important part of this. I don't have any advanced degrees in quality or management or administration related to it. I didn't take any special training. I'm a surgeon who just jumped in with the recognition of the need that if we don't own this process, it is going to own us. And so while you may have looked at the great work that you just saw and thought that a lot of these terms are new to me, or I may not catch on exactly what they're saying, I put it to you and I would leave it as the take-home message that we all need to, because it's going to dictate how we practice, and we need to be on top of it. So I was going to tell you a little bit about the committee. Quality outcomes and safety seems like a huge bucket to put into one committee, and yet it is impossible to talk about any one of those terms without including the others. And so the committee, which is made up of like-minded surgeons who just want to do the right thing for patients, that is the best part about what this committee does for this organization and for its members and for you and by proxy your patients, is everything it considers is what is best for the patient, not as what is best for us, what is best for our administrators, or what is best for our hospital, what is best for our patients. And I love being on a committee that centers that question into every discussion that goes through it. I'm going to talk to you about a few of the initiatives that are ongoing and how they apply to that, and how it really dictates what we see as our mission. And the mission's pretty broad. I put it in really small font and you don't have to read it, to emphasize the point that it has a wide task and a wide commission on what it needs to do. It educates its members, it advocates for its members and its patients, it liaises with other committees, it liaises with the government and other bodies who are dictating some of these processes and these requirements on us. It interprets them, it evaluates them, and it tries to explain and develop them for our membership and, in a sense, protect the membership by educating us. My interest in this was born out of the frustration of just what was mentioned earlier, that what is quality? There is a rush to judgment of surgeons and hospitals and processes and outcomes. We really have no clue what that judgment, what the metrics are that go into that judgment. Does readmission really tell? I mean, mortality seems like an easy one, but everything that we throw in, is that really what quality is? And one of the big missions and the core parts of these conversations that we have at this committee is to try to determine what quality is. And we got the lesson, or at least I got the lesson the hard way. And my introduction into this committee started with the National Quality Forum, and that is a committee that we are now, SAGES is now a organizational member of as of 2015. We don't have any individuals on these committees. It is a nonprofit organization that doesn't create metrics. It has metrics submitted to them, it evaluates them and endorses them. What has become why they have gained the prominence that they have is they have CMS's ear, and CMS uses the metrics that they endorse to then utilize in its reimbursement structure. SAGES first started reviewing some of the metrics that were being sent to NQF, and it can come from anywhere. It can come from university or healthcare think tanks. It can come from insurance companies. It can come from a lot of people. And they evaluate them and they endorse them. The first one we looked at was 2 years ago that related to surgery, and it had to do with all-cause 7-day readmission rates for outpatient surgery. And that was a metric that they wanted to endorse, and we immediately saw problems with this metric, which was essentially all but endorsed, meaning if you did an outpatient laparoscopic hernia, and your patient showed up in the emergency department with poison ivy from working in their yard 3 days later, that was a hit on you. If you have a patient base where you need interpreters to talk to your patients to give them post-op instructions, and they have a higher likelihood of coming back to the emergency department and needing explanation or just not understanding what showing up with poor wound care instructions or diet instructions. That was a ding on you. And so we fought this from the point of one, we didn't think this really was a good measure of quality at all because of all of those external confounders that could affect it. And two, we saw it as a problem for access for patients, that if you knew you had a patient base that was more likely to show up in an emergency department, are you going to be less likely to want to take care of those patients? And the metric through NQF argued the point that, well, we've looked at quartiles, and with risk adjustment for outcomes in hospitals of different demographics, there's no statistically significant difference. I have way too little time to tell you what I think of the word risk adjusted, but I think even if that is a reality, reality doesn't drive access, perception drives access. And you can't tell a surgeon that there aren't going to be differences in how difficult or complex a case that you may take on. We fought this. In the end, it was a little bit of a deflating process because these are done deals, and essentially it was a done deal. But it taught us a great lesson, and the lesson is we can't play defense. We can't keep taking fire from all these agencies of how we're going to be judged and how we have to take care of patients and what their definitions of quality are. And you've heard it in every presentation here that while we may not think it is in our realm to have to jump into this pool and start using these terms, and we may have a visceral reaction thinking that we need a Rosetta Stone to interpret all of these words that we now have to learn in this language we have to speak, but we have to, because this is what happens when we just take it on the chin and we play defense. So we need to start playing offense. So we attend the NQF annual conference every year. We still review all of their metrics that they put forward, and we'll keep engaged with them. Another project that we just started in the past year and a half, there are a lot of hospital ranking systems. And to go back to the point of how do we define quality, what's a good metric, I'll give you a quick quiz, and this is based on Johns Hopkins data, Marty Macri. If you take the biggest and most common hospital ranking agencies in the country, if you take US News, if you take Yelp, if you take Health Grades, if you take all of those, do you know how many hospitals in this country are on all of the highest performer list of those ranking systems? Zero, because they're all based on different metrics. So which one's right and which one's wrong? And who knows what the best thing is? Nobody. But we're being judged. The rush to judgment has occurred. And when I hear people saying this is coming, it's not coming, it's here. We're in it, we're living in it. So when US News approached SAGES, the QoS committee, through Dr. Macri actually, to say, help us with these rankings. We don't want to base this on reputation anymore. We don't want to base this on things that content experts don't believe are the right things to be in these rankings. We took the bait. We said, this is great, we'll have this conversation with you. And they are now not to single them out, but to their credit, they are now going to specialty societies and to content expert organizations and saying, you help us with the metric, you define what this is. So as a pilot to this, we also chose colectomy for some of the similar reasons, but specifically in conversations with them and what they wanted, what we're looking at with them is the percentage of colectomies, not for rectal, but for single elective, for colon lesions, not for diverticulitis, not emergent, but elective colectomies for single lesions. What percentage of those are being done minimally invasively? Now, there are some drawbacks to giving a metric. And if you look at the variability in colectomy, it is the widest of the common ones we do. We didn't choose appendix or gallbladder because those are all skewed on one end already. We didn't choose hernia because there is conflicting data and still some discussion about what. But colectomy, there is definitive data to suggest that, again, not for emergent or for rectal lesions, but for single lesion colectomy, that MIS utilization, of course, offers some benefits over open procedures without being inferior. the range goes from 0 to 70% or 80%, and in a small few cases, I should say the range goes to 100%. But if you look at the middle quartiles, it's in below 50%. And we set a task force out, and the number that they're looking at is suggesting this is still an evolution, but 11% of the procedures being done minimally invasively is the 25th percentile in this country. So we're actually looking at 10%, which is below the 25th percentile. That leaves a wide range of room to say all of the arguments which are now going on in your head, which is, what if my judgment says this is better open? What if I have to convert because it's safe? It allows all of those judgments. Really, to be on the red zone of this, you have to be at 0. And what we're saying is that it's no longer a standard to not at least suggest that laparoscopy has benefits and to be 0. And just to give you, we're still in conversation. This is not there yet, but we're still having these discussions with them. But we are engaging as a committee, as a representative, to at least start to put our toe in the water to say, we're going to start playing offense. We're going to start defining what you call quality for our community. And this is just the first way we're going about it. This is just for hospital rankings. We've had discussions about surgeon rankings, which is in the future, but it's coming. It's coming, and it'll be the same types of metrics. The last one I'll tell you about, and I know we're going to try to finish up quickly here. Has anyone heard of Choosing Wisely? It is an initiative by the ABIM Foundation and Consumer Reports to set a conversation, is how they describe it, and it's not meant for specialists. It is to give broad standards that specifically hit the area of reducing unnecessary costs and procedures, and it's geared towards patients and physicians. It is not meant to be in controversial areas. It is not meant to be, you know, do I drain this or not? It is very, very basic on the level that there would be no discussion as to universal agreement to these standards. And specialty societies are the ones that are submitting these, and they're freely available online. ACS has some, even nursing has some on here. SAGES is going to start getting into this game. And there are things like, you know, not everyone with belly pain needs a CAT scan. Not everyone you're going to operate on with an inguinal hernia has to have an ultrasound. I mean, it doesn't mean you can't use it in cases you think it's required, but it takes away universal application of things that just shouldn't be triggered universally. And we have a task force that's setting out to what that would look like for the minimally invasive community. All right, so I just gave you a few of the bigger projects that we're working on. The one thing I also want to give a quick plug for is the other benefit of an organization like SAGES in looking at these quality measures is we can have the second part of the conversation, which is if looking at the hospital metric, which soon to become surgeon metric for MIS utilization for colectomy. Well, if you're on the low end of that, now what do you do? If you just handed this slip that has red all over the page and you're on the bottom end of it, what do you do? SAGES can also offer the education side of it. SAGES can also offer the resolution side of it. Most of you know we have an ADOPT program here, which is a longitudinal mentoring program for hands-on courses. Well, at this meeting, tomorrow night, we're doing laparoscopic colectomy, and which will be done at Mighty, and it'll be an intense 4-hour experience with a mentor that then those participants get 12 months of webinars and interaction and case presentations and such. So SAGES is offering programs like this to not only throw the metric at you, but then do something about the metric. So there's one spot left, by the way, in that course, and that's Erin Schwartz. She's the administrator for the course, if you're interested. Anyway, that's my last plug. So the take-home point I want to leave you with is the exact same one you just heard, which is keep it patient-centered, that all the metrics will follow. We shouldn't turn ourselves into pretzels trying to figure out what the government wants or what insurance companies want. If we keep our metrics basic and simple and what is best, what is going to give my patient the quickest and easiest and nicest recovery, those are the things that'll survive. The threat is not looming, the threat is here, and we need to own this. So as much as it is difficult, if you have as little training and understanding what all this means as I do, educate yourself. It's coming. It'll affect your livelihood, and it'll affect your patients. Thanks for your attention.